Hi, everyone. Thanks for joining us. I'm going to give it about one more minute because I still have a bunch of people in the waiting room who are the little dots spinning as they're joining in. So I'm just going to let them finish getting in here. Then we'll rock and roll. All right, that's good for now. Let's get started and I'll get the rest as they come in. Thanks for joining us, everybody, for this session in our Ask the Expert series. Dr. Cuddeback is going to be joining us to discuss specialized mental health caseloads and probation and lessons learned from the implementation of these caseload types in a large southeastern state. Session will address the complex needs of justice-involved individuals with serious mental illness and how specialized caseloads create additional opportunities for collaboration with mental health services. If you have a question during the session, Doctor, would you like them to ask immediately, unmute themselves and ask, or just save it towards the end?
No, and Gary, please. Let's go as questions come up, feel free to interrupt and ask.
All right, sounds good. So if you can just unmute yourself to ask the question. If you can't get yourself unmuted, whatever works, you can put it in the chat directly to me or to the group, and I'll make sure I send it. And if you don't feel comfortable asking a question, feel free to send it to me directly in the chat, and then I can hold it to the end or whenever. So that's it, Gary. I'll kick it over to you.
Okay. And let's see, pull up the slides.
Okay.
So welcome, everybody. I'm delighted to have an opportunity to talk with you this afternoon, at least where I'm at. Gary Cuddeback. Right now, I'm at Virginia Commonwealth University in the School of Social Work. A lot of the work that I'll present, I did while I was a professor at the University of North Carolina, Chapel Hill, and I came up to VCU in 2021. So the work here that I'll present will span both VCU and UNC. So I'm a mental health services researcher and intervention researcher, and specifically focus on developing and testing interventions at the interface of mental health, criminal justice. So folks with severe and persistent mental illnesses is really what the focus of my research is on. So you'll see a lot of that today. And I'll just talk about findings from different studies I've done, and then my experience setting up specialized mental health caseloads in North Carolina. As Steve and I said a moment ago, feel free to interrupt as we go, and we'll see what happens. I think we have 6 hours, Steve, is that right? Yeah, right, 6. No, I'm joking.
At least 6.
Yeah, 6 to 7. All right, sounds good. All right, so next slide, please. There's a number of grants, and I'll be talking about findings from these different projects. So that's why this is up here. And unfortunately, I don't have any conflicts of interest. I'd love to have some of those, but I don't. So next slide. All right, so to sort of set the context here, talk a little bit about what I mean when I say severe and persistent mental illness. And really that's the folks living with the conjunction of diagnosis, disability, and duration. And this comes from a seminal article back in the 80s when National Institute of Mental Health in particular was interested in defining and counting folks with mental illness. So the 3Ds, diagnosis, disability, and duration. Diagnosis really referring to the more severe mental health disorders like schizophrenia, schizoaffective, bipolar disorder, delusional disorder, psychosis, major depression recurring with or without psychotic features, post-traumatic stress disorder. So starting with one of these diagnoses, being disabled by the symptoms of these diagnoses. So really unable to live independently without treatment and care. And I've got that bullet under disability. Early in my a short and less than illustrious career, I did a lot of work with administrative data, and defining someone with SPMI in a Medicaid data set, for example, is tricky in the sense that there's no SPMI indicator. You have to piece together information from a variety of different sources. So if I saw, for example, a long stay in a mental health hospital or multiple stays in a regional or local hospital, there was usually an indication of a disabling disorder. And then duration, similarly, if someone had evidence of supplemental security income or SSDI, given what we know about the length of time it takes to get someone enrolled in those programs, that usually is a true indicator that someone has had a disabling diagnosis, if you will, for quite a while. So when I mean severe and persistent mental illness, I'm really talking about those chronically, profoundly mentally ill individuals in and out of hospitals, in and out of jails, homelessness, substance use, et cetera. So really the deep end of the spectrum of mental health disorders. All right. We can pause there. I don't know, Steve, if anyone chatted anything, but happy to see if anyone's got any questions about the definition we're going to use throughout the rest of the talk. All right. So criminal justice and mental health really are now intertwined, unfortunately. If we think about the public mental health system, it's really shrunk over the last 50 years. Really, the folks we're talking about resided in large state mental health hospitals, and say what you will about the quality of the care there and the treatment. Care and treatment work together in those hospitals. If you think about it now, after deinstitutionalization and a number of other policy events, folks with severe mental illness are out in our communities, and where care and treatment are very much separate. So you have to go one place to get housing, another place to get substance use treatment, another place to get food or food support, food stamps, another place to get health care, another place to get benefits. So all these systems now have to be navigated independently and separately, which is very difficult for someone with a mental illness. Where in a state hospital, right, there were meals, there were recreational activities, and there was treatment all together in one place. So that's made things awful difficult for people with severe and persistent mental illnesses. Also, the criminal justice system is really a setting, unfortunately, for mental health services research. So if I do an intervention study and I need subjects who have severe and persistent mental illness, the mental health system, courts, jails, prisons, probation, parole is a place to go to find those folks. Also, fates of people with severe and persistent mental illness are closely intertwined with our criminal justice policies. I'm sure you've seen evidence in your own town or city where you pass a new ordinance prohibiting panhandling or soliciting. It's going to impact those who are most marginalized and vulnerable, which typically are individuals with severe mental illness who are homeless, have substance use issues. So if you tweak the criminal justice system, it has, often has implications first and foremost for those most vulnerable and marginalized. And then the criminal justice system really is the place of last resort, if you think about it, for folks who are hard to engage, hard to manage, out of control in the community. So jails have no front doors. Anyone can get in, whereas it takes something very specific to get into a state hospital, as we all know, which are very hard to get into. So place of last resort, also a public health outpost, and it's kind of a funny way to think about the justice system, but can often be someone's first and best chance to get diagnosed with a severe and persistent mental illness through a jail screening or probation, parole, or prison. And a health condition. Jails and prisons are constitutionally mandated to provide care if they find that someone is in need of care. So it's funny to think that someone gets diagnosed first with cancer. There's nothing funny about that, but that someone would first get diagnosed in a jail or prison and have to be treated accordingly. So jails and prisons are really a public health outpost, identifying those with mental health and physical health and substance abuse needs. Excuse me. I'll pause there. Any reactions, thoughts? Steve, you're still awake? Yeah.
I'm over here. Yep.
All right.
Still in there.
I see you. Yeah. Okay. Next slide. All right. So on any given day, we've got about 37,000 people across. Oh, there you go. Across the country, in our large state mental health hospitals, and juxtapose that. How many of you appreciate I use the word juxtapose? All right. Thank you. I'm here all week. Juxtapose that number 37,000 with over 250,000 in prison, 130,000 in jail, and almost 1.5 million people with mental illness on probation or parole, which is an astounding set of numbers if you look across. Now, the red oval is around jails there because, as we all know, jails are quick turnaround, short-term facilities with about 14 million, 15 million annual admissions, probably 10% of those. So over 1 million are folks with severe mental illness. So that number is probably closer to 1 million. The justice system, which is not a system at all, really, has been forced to develop its own set of interventions and policies and strategies to try to address people with mental illnesses in that system. So we've got crisis intervention training for police officers. We've got mental health courts and other specialty courts. We've got screening and treatment in jails. We've got critical time intervention to help folks who are released from institutional settings have better community reentry outcomes. Got issues around restricted housing and prisons doing both CIT and risk and needs assessment. And with probation, and we'll talk about this today, we've got mental health training, we've got specialty mental health probation, we've got special risk and needs assessments that are applied to this population. So unfortunately, folks with mental illness are very much a part of integrated with the criminal justice system. All right, next slide, please. So really are complex needs of justice involved individuals. And I'll make the case that when you layer on, so needs are complex enough for someone living with a severe mental illness without justice involvement. Once you layer on the justice involvement, it becomes even more complex, and the more barriers, more difficult to serve. So we've got a lot of loneliness, stigma, and isolation. We've got lots of unemployment. I think the unemployment rate for folks with severe mental illness is like 85%. And I don't know what other population we would settle for an unemployment rate that high. Of course, we've got lots of substance use and more dangerous substances with opioids and fentanyl and other things hitting the market for some time now. Got chronic physical health problems. And also homelessness. So think about these different public sectors represented here. Again, these are the public sectors that people with mental illness are trying to navigate, each with their own Byzantine bureaucracies and eligibility requirements and funding requirements. So then the justice system throws a number of additional policy barriers. So getting housing with someone with a criminal record, a criminal history is that much harder. Getting a job, as we all know, with a record and a criminal history makes it that much harder. So particularly for people on probation, where the expectation is you get a job, you get safe and affordable housing, those things are much more difficult for someone with a severe mental illness than you or me, for example. All right, I am delighted that we have a question in the chat. Is there a movement to incorporate mental health therapists into probation parole department? Yeah, that's a great question, Tasha. In some jurisdictions, but this really takes criminal, if you think about it, and that's a great question, criminal justice beyond its original mission, right? Which was to protect public safety. And the pendulum in the justice system has really swung back and forth over the years. So are we social workers or are we probation officers? Are we social workers, probation officers? So depending on the innovation, the foresightedness of the probation jurisdiction, you may see mental health therapists right in the unit. I think that's pretty rare, though, although that's a great idea. On my most cynical days, I think we ought to just merge Department of Mental Health and probation and parole, just because of the high volume of people with mental illnesses in the justice system. And that's a good thought. And I've written grants to try to get the two integrated, or put, for example, a forensic assertive community treatment team into a probation unit to remove all those barriers between those two systems. So great question. And I think what would need to be overcome is sort of the philosophical differences between mental health and criminal justice in terms of primary mission, and then just some of the logistics and barriers around credentials and disciplines and so forth. So good question. Thank you, Christine. Ventura County, indeed, for the youth population. That's right on. So you're seeing more and more of this. It's going to take some more innovation and some more thinking and more collaboration between the two systems, really, to make this mainstream. All right, good questions.
Gary, I got another question here that came in.
Great.
I think it's back on this slide. And are these numbers Illinois specific?
Oh, no, this is just across the country.
Across the country.
Yep,
Perfect.
thanks.
Thank you, sir.
Good question. All right, next slide. So these are data from a study I completed recently, and enrolled 204 individuals on probation with severe and persistent mental illness into a study of regular probation versus specialty probation, and collected data on mental health functioning and trauma and social support and a bunch of other things. And I got to get oriented to the new color scheme. So the groups were divided. So 204 folks divided into those with low social support and high social support. And what the one on the left is suggesting is that folks with low social support had higher mental health service needs compared to those with higher social support. And similarly, the same graph on the left, but the column on the right, you can see those with PTSD, or those with low social support also had greater levels of greater percentage, that is, of PTSD diagnoses. So here, low social support was associated with a number of other poor outcomes. And then the one on the right, if you look at mental health functioning with higher scores, meaning worse mental health functioning, those with low social support also had worse mental health functioning than those with higher social support. So the slide I showed a moment ago with the complex needs, this really shows social support, stigma, isolation as being a problem for this population. All right, next slide. Same set of 204 probationers with severe mental illness. I asked about cumulative trauma. And trauma, I think, is the next frontier. And we've already seen quite a bit of this in the literature and national dialogue about being trauma-informed this and trauma-informed that. The justice system being no different, right? Matter of fact, I can't think of maybe child welfare would be a rival in terms of the population and exposure to trauma, right? It's a highly traumatized population. So what this graph says, first of all, the dark bars on the left of each grouping here, 80% of these 204 probationers with severe mental illness experienced a physical assault, 60% an assault with a weapon, 50% sexual assault, 40% life-threatening illness or injury, and 90% experience at least one of those interpersonal traumas. So I want to put all of this in context now, and this will be the theme that we thread throughout. You're thinking about serving this population in a specialty probation model or even a regular community mental health treatment model. These are all the different challenges you're going to face as a provider. Okay, so you've got population with complex needs so far. We've got low social support and stigma, high stigma. Now we've got all this cumulative trauma, which has lots of implications for establishing therapeutic rapport and engaging folks in treatment, sustaining treatment, trust, and so forth. So highly traumatized group. And then half of this sample, and that's the difference. You'll see the gray bar and the light blue bar, Carolina blue bar, is half of the sample of 204 met diagnostic criteria for post-traumatic stress disorder. Now, in the general population, the rate is like 4 or 5%. In this population, at least in this study, it was 50%. So got a highly traumatized population, half of whom have a full-blown post-traumatic stress disorder. A lot of these folks go undiagnosed, untreated, right? The trauma is often masked by substance use, by some of the other symptoms associated with these mental disorders. All right. Physical health problems, we touched on that as well. These are data from a study I did years ago comparing folks with no mental health disorders, those with severe mental illness who were not involved in the justice system, that's the gray bar, and then those with severe mental illness who were justice involved, that's the light blue bar. So you can really see across the board, folks who were justice involved, who had severe mental illness, had greater physical health problems, more infectious diseases, more blood disorders, more skin disorders, more injuries, right? And these are from Medicaid claims data. If you think about this from a public health perspective and tying this back into the notion that jail is a public health outpost, you start someone on treatment for tuberculosis in a jail, right? You jail screens, finds that's an issue, has to start someone on treatment, but then they get released right in the middle of their treatment regimen. There's unfortunately in a lot of jurisdictions, maybe yours is different, little communication between criminal justice and public health. Hey, local public health, Gary just got out of jail. He's 3 months through his 6 months of tuberculosis treatment. Can you find him, right? And make sure his treatment resumes. So that often is not the case. So it can be a real public health issue as well, with little communication between these public sectors. And these are, I also picked, there were other physical health problems in the article I published, but these are 4 that, or 3 at least, that you don't want folks walking around in our communities without treatment, right? We don't want folks with infectious diseases who are potentially exposing others, same with blood disorders and skin disorders. So again, rounding out this notion that these folks have complex needs that have implications for treatment is the context here in the picture we're painting. Okay. Questions, thoughts, responses? You got anything in the chat, Steve?
Nothing yet.
Okay. Service needs among people on probation with severe mental illness. Same sample at 204. Just ask them if their basic needs, other needs were being, if they had them and if they were met. So this sample, 60% had unmet basic needs, food, clothing, shelter. 70% had unmet medical needs. 70% had unmet dental needs. Matter of fact, I think dental pain is one of the top 3 reasons folks go to the local emergency department. I think it's back pain, cardiovascular stuff, and then dental pain. So a lot of folks going without dental services. Outpatient mental health care, a lot of folks going without that. A lot of folks going without medication. Next slide. 70% did not have a valid driver's license. 60% were transitory, houseless, homeless. Only 60% were Medicaid enrolled, and these were folks with severe and persistent mental illnesses. So all or almost all should qualify for that insurance program. Only 50% were currently in mental health services, and almost 50% had a prior probation term. So again, putting this in context about the complexities of serving this population, not only do they have all these problems, stigma, social isolation, chronic physical health needs, substance use, but they've also got unmet basic needs. So you're trying to engage them in treatment, trying to serve them, and they've got food, clothing, shelter priorities that are well beyond treatment for mental health conditions. Okay. Next slide. There's also some demographic and clinical characteristics. And again, this is rounding out the complexity of serving the justice-involved population. These figures represent differences between SMI with no justice involvement versus justice-involved SMI. These come from data from a large community mental health agency in Ohio that I was working with at some point. Dark bar are justice involved, and you can see across the board a little more complex in terms of demographic and clinical characteristics, more harder diagnostic profile with folks with justice involvement, more antisocial personality disorder, more homelessness, and more substance use. So layer on again the justice involvement, and things become much more difficult with this population. Next slide. Similarly, and this is a busy table, but same study and same agency from Ohio. What I want to highlight for you is just those clinical risk factors at the bottom and the differences. And these are individuals served by the same jail diversion assertive community treatment team from one agency. And what I did here was look at differences between male and female and how they might differ clinically and demographically. But really at the bottom, you can see there are different issues for men versus women. Women experience more interpersonal violence, sexual abuse. Men experience more treatment engagement issues, noncompliance, and homelessness. So if you're setting up treatment plans, whether it's specialty mental health probation or a community mental health service, attending to the gender differences, right? The different experiences versus men versus women is really important when you're doing program planning and services. So these are important. People with mental illness are not a monolith, right? Not one and the same. And this table highlights some of those differences. All right. Thank you. All right. So a lot of the notion of the, justice system and their orientation, and this goes back, Natasha, to your question, incorporating mental health therapists into probation parole. There's a notion that if we can just get folks with SMI back into services, then their justice involvement would go away. And I'll come back at the end and say, I don't necessarily believe that that's true, but that's sort of been, if we think about our interventions, the intent that we just need to get these folks back into mental health treatment, and then all the problems will go away. Well, there's a lot of reasons folks can get into the justice system, right? That have nothing to do with mental illness, right? If you think about it that way, a lot of justice involvement has nothing to do directly with mental illness, and by that I mean just symptoms and disorders. But it's the stuff that goes along with severe mental illness that really are some of the driving factors that I'll talk about as we go. Nevertheless, a lot of our interventions are focused on connecting justice-involved people with SMI to mental health services. I'll make the point that it goes beyond just connecting to mental health. All right, next slide. This, and I don't know if your state has a Medicaid restoration policy, expedited Medicaid restoration policy. These are data from Washington State, a study I did a while ago, which has an expedited Medicaid restoration policy for folks who are on Medicaid prior to entering an institutional setting. Before release, they try to get the paperwork done and turn Medicaid on once folks hit the community. So really, this is a simple graph showing outpatient mental health service use within 30 days of release from these institutional settings, prisons, jails, state hospitals, for those who are approved for expedited Medicaid versus those who are not approved. And you can see across the board, folks who were approved had much greater outpatient mental health service use within 30 days compared to those without. Now, look how, then these are folks with severe mental illness. Look how poor community reentry is for folks coming out of prison. Even those who had Medicaid, less than 40% received any services within 30 days. So it's no wonder why recidivism is high, relapse from substance use is high, and actually death rate is high in a short window following release from prison for this population. Jails look a little better, state hospitals look good, but there's only one way to get into a state hospital, right? That's if you have a severe and persistent mental illness, which by definition typically qualifies you for Medicaid. And these folks were also likely connected to ACT teams and other services that took them back after release from those institutional settings. All right, so if your state doesn't have an expedited Medicaid restoration policy, then there's an opportunity for you to work with your legislature to get that done. All right. Questions, thoughts, comments? Even then, with state hospital in California, yes, that's exactly right. I mean, thank you, Natasha. Those horror stories that folks are released at the bus stop, 2 a.m., with $7 in their pocket and a slip of paper with their next appointment 2 weeks from today to the local homeless shelter. Unfortunately, those still happen. All right, next slide. All right, sociologists, criminologists, they're worried about other things than mental health services, intervention researchers, providers, right? Where mental health is focused on providing mental health services. But probation officers are thinking about different things. They're geared up to think about these criminogenic risks. And if you haven't heard of these, it is a good example of sort of the not rift, but the difference between the two systems, right? These are after years and decades of looking at factors related to justice involvement, researchers have settled on these 8 factors, and the 4 that are bolded are known as the big 4. And this is antisocial behavior, antisocial personality traits, antisocial cognition, and antisocial peers, right? So these are the things that probation officers are trying to address, along with substance use, job and housing, and so forth. So if you hear probation officers talk about criminogenic risks and CBT treatment to address criminal thinking, this is what they're focused on. They might have worksheets that they give for folks to work through these, but there's a whole set of activities around addressing these. Now, I know what you're asking yourselves. Is there a synergy between mental health and criminogenic risk? Because you'll note mental health is not a criminogenic risk here. Substance use is, and I would argue that substance use is one of the primary drivers of justice involvement for folks with mental illness who are involved in the justice system. But you'll see that mental health is not one of these criminogenic risks. Synergy, you ask? Next slide, please. So these are data from North Carolina, and it's looking at these criminogenic risks between folks without SMI, those are the dark blue bars on probation, and those with severe and persistent mental illness, those are the gray bars. You can see across the board, those with severe mental illness have greater levels of these criminogenic risks. More substance use, greater antisocial personality traits, antisocial family history, functioning, poor impulsivity and self-control issues, and antisocial values. So now combine these things, which this is what probation is trying to address, with mental health symptoms that are not well managed, and you've got a very difficult, complex case for the probation officer, as well as community mental health provider. And folks with severe mental illness on probation don't do well. They have greater violations, revocations, and all sorts of other infractions and poor outcomes. So again, the layering on of the justice involvement or the complexity of both mental health and justice involvement is associated with a very difficult complexity and profile. All right, so you're probably asking, next slide, please, if this holds up in prison. It does indeed. These are folks in prison, SMI, whoops, back up one, Steve, there you go. Same set of criminogenic risks, but this time it's with people incarcerated in prison. And with one exception in the second from the right, antisocial personality traits, folks with SMI have greater levels of these criminogenic risks in prison. And prison is a place where, in jail for that matter, you have to follow rules and instructions, right? And you have to do what's expected of you. which folks with severe mental illness have a hard time doing, often resulting in infractions, administrative segregation, housing restrictions. It's just not an environment for someone with a severe and persistent mental illness. Okay, next slide. And these are, as I said a moment ago, these are data from North Carolina prisons. Folks with SMI have more infractions and are twice as likely to have any infraction within the first 6 months of prison entry compared to those without SMI. And here's some of the top 5 infractions in case you were wondering what goes on in a prison setting. These are the things that people get in trouble for. Think about someone with a severe mental illness who's paranoid, hallucinating, not well managed with medication, hearing voices, and now a correctional officer is giving them instructions that they can't understand or being told not to follow, right? So you can imagine how quickly the environment for folks with SMI in a prison will spiral out of control. Okay. I'll pause there while I take a sip of water. We'll wait for questions in the chat, comments, emojis. I'll take anything at this point. Oh, there we go. Thanks, Steve. All right, next slide. Okay, so those other things I mentioned, yes, we can address mental health, but it's not just about mental health, right? And here we've all, been talking about for years social determinants of health. Well, I've crossed that out, as you see. You can really think about social determinants of justice involvement for people with SMI. It's these other things, and I have this. Thank you, Emilio. I appreciate the enthusiasm there. Right back at you. I have this annoying way of characterizing what folks need, especially if they're leaving institutional settings and are trying to be successful with community entry. They need a bed, a buddy, and a job, right? Don't we all need a bed, a buddy, and a job, right? We need safe and adequate housing. We need social support, pro-social support, family support, and we need meaningful employment. So we got to take care of some of these social determinants. And then, in addition, address mental health, substance use, these other things, right? But if we're not giving folks just a basic foundation of what we all need to survive and thrive, then we're not going to make much progress on addressing the needs of justice-involved folks by just addressing mental health. So, this is policy. I can guess without seeing anybody on the screen, if I were to ask for a thumbs up or a thumbs down, do you have enough safe and adequate housing in your community? It would all be thumbs down, right? There's plenty of housing in my area here outside of Richmond. Housing is going up like crazy. It's not affordable housing, right? People are being priced out. Even people without mental illness can't afford housing. So think about what it's like for someone on a fixed income. I think supplemental security income is $775 a month now. Imagine, trying to meet all your bills and afford safe and adequate housing. Supported employment opportunities. Do we have enough of those to go around? And then pro-social support, social connectedness, meaningful engagement in our communities. So bed and a buddy and a job. Indeed. Thank you, Natasha. If we're not getting these basic needs met, then it's difficult to do much else. And if you think about, and this goes back to the notion, can we put, all of these things, addressing these systemic issues, these social issues, if you think about it, have been laid on the doorstep of the justice system, right? Which was never designed to be the primary providers of mental health support and housing and social support and getting folks jobs. That's not what it was designed to do. But really, because of the number of people who have ended up in the system, that's what probation officers are trying to do. So I've done a lot of work with probation officers, a lot of really, well-meaning people trying to do the best they can with limited resources, limited training, very difficult job to do. And I've sort of laid out now, and not sort of, I hope I've laid out just the complexity and all the different issues both the population is experiencing and those trying to serve them are up against. All right. So if you remember nothing else, bed, buddy, and a job. All right. Let's next slide, see what comes up next. All right. So a couple of things I've done, and I'm happy to share this, and there's a link there too. But when I was in North Carolina, I worked closely with probation. One of the things that I helped with was create a statewide mental health training for all probation officers. Um, Whether probation officers have a specialized caseload or a regular caseload, there are people with mental illness on those caseloads. You can, yes, Natasha, you can go onto that website and get those modules. And then if you have any questions, I'd be happy to answer those. And I think my contact information will come up maybe at the end. If not, I'll put it in the chat. They are North Carolina specific. You are welcome. Thank you for your engagement and interaction. The first one is North Carolina specific. And what North Carolina has is a brief risk and needs assessment around mental health. And there's really just 4 mental health screening questions that'll sound familiar to you all. And it's from the perspective of someone on probation, but I see and hear things that others don't see and hear. Sometimes I have so much energy, I stay up for days on end. I feel so badly. I feel like killing myself. And there was one other, but really trying to get at clinical depression. The other one was sometimes I feel like people are putting thoughts in or taking thoughts out of my head. So trying to get at psychosis, bipolar disorder, depression. So that first module, using and interpreting the risk and needs assessment, is geared towards if someone answers affirmatively to one of those 4 questions, rather than ignore it, which, might be tempted because I don't really want to talk about the voices you're hearing. Gives probation officers guidelines and prompt questions to get more information. Second one is really just severe mental illness 101. The third module is psychiatric medications. The fourth one's PTSD, personality disorders, other disorders. 5 is laying out crisis response services. What's an assertive community treatment team? How do I get mobile crisis? And 6, which was very popular, was self-care for probation officers, where the suicide rate among probation, especially retired probation officers, is relatively high compared to other disciplines. I did create more modules that might be up on the website. There's one on substance use. There's trauma-informed care, PTSD. So feel free to go there and poke around. But then also feel free to contact me for more information. I did a brief pre-test, post-test knowledge. Had over 300 probation officers do these modules and checked mental health knowledge before and after, and mental health knowledge increased. Also perceived stigma decreased, which is important because there's evidence that the less stigma we feel towards somebody, the more likely we're going to be to help them. So not a particularly fancy or sophisticated analysis, but it shows mental health knowledge improved and stigma decreased, which is good. You want a population of probation officers to be better equipped, better informed. This was a strategy to do it. All right, next slide. So mental health training, and then set up a number of mental health probation units. And basically what this was 2, sometimes 3 officers supervised by a chief probation officer who were going to get specialized mental health training. So we gave them training, we gave them caseloads of people exclusively living with mental illness. We gave them a reduced caseload of 40. They got ongoing training, as I said. They had coached up to do a problem-solving supervision orientation. So let's think about treatment options rather than revocation or rather than some criminal justice response, if appropriate. One of the important lessons here is mental health, with something like this, as a ivory tower researcher, I was entering criminal justice world, and they have a primary mission of protecting public safety, which is very important. So in doing these probation caseloads and the training and so forth, at no point did I do or say anything to compromise that mission. If they needed to arrest somebody, if they needed to incarcerate somebody, then that was their call, right? So understanding the difference in mission, the difference in language, the difference in priorities, and being able to operate, within that system is a really important lesson. And then lastly, a greater interface with external resources. So the other unique feature that credit to North Carolina, they allowed a licensed clinical social worker to do monthly staffings and supports with each probation officer in each county or units of probation officer. So literally the LCSW would sit with the probation officers, talk about their cases. If they had a particularly challenging case, they could staff it. And it was also an opportunity to provide more information about medication, potential services that might be a support, and so forth. So really a unique feature that was really successful. I think that's the part that the probation officers liked more than anything, is just the ongoing contact with a licensed clinical social worker. Sometimes it was just support around you didn't have success with this case. And that's the other part. We didn't expect 100% success with these very, very difficult cases. And often they failed. People went back to jail, people went back to prison, people died, people relapsed, and it was very stressful and very difficult for these officers who were trying so hard to go to extra lengths to serve this unique population. So just supporting the officers around, you don't expect to have success in every case, or that was a particularly difficult case, and it certainly didn't turn out the way you expected it to. So that was an important feature too. All right, I'm going to pause here to see if anybody has any questions or comments. Okay. All right, next slide. I said this. So that really the supervision expectations here for these officers were a little greater than the regular minimum requirements. And we carefully selected officers to be specialty officers, and they sort of knew, because of their background, some of them did have mental health backgrounds, and some of them were attracted to these positions just because they wanted to help and realized that this was a particularly needy population. So asking them to go beyond the regular minimum supervision requirements was not a difficult ask at all. So there was direct and increased contacts between officers and mental health providers. Because of the reduced caseload, the officers had more time to reach out to local providers and establish those relationships, which are just critical. Those of you working in community mental health, you may have different experiences trying to reach out to probation, right? They may or may not return their call, vice versa. So these officers had an opportunity to really bridge and establish relationships with social service providers in their communities. One other thing we did thank you, Natasha. I will come back to that in a moment. Is there a structure for this or policy manual? I'll come back to that in a sec. Let me finish my thought. One thing we did in setting these up is we'd have a kickoff breakfast where we'd bring in the officers, but then as many community providers that worked with this population, and sort of introduce everybody, exchange contact information, set the tone for how we wanted mental health probation to work and interface with the local community and so forth. So those were pretty successful, especially because we were able to bring in food, and everybody loves a sausage breakfast, scrambled eggs, right? English muffins. So Natasha, let me see. Yeah, we do have a training manual, and let me see about getting you a copy. I'm going to put my email in the chat, and you can email me and we can follow up offline. All right.
Gary, while you're there, there's also a question about the supervision expectations and what the averages were as far as contacts with the individuals on the
Yeah.
probation end.
Yeah, so the average for regular probation, and it varied by supervision level, right? If they were high risk, it might have been twice a month in terms of a field check-in and an office check-in, even for the highest risk regular probationers. For mental health, it was much more than that, and it was left up to the discretion of the officers. The expectation was that they would do more than the standard supervision requirements, but were left to determine on their own. What ended up happening is, dozens of contacts during a month, right? So many more to address all those social determinants that I mentioned, getting folks connected. So probably a couple times a week, either in person, phone or texting, or what have you. So much, much greater frequency than regular supervision. All right. Okay. So you got the model. Again, the model, if you back up one, Steve, probation model really is exclusive caseload of folks with mental illness, reduce caseload of 40, ongoing officer training and support, problem solving supervision orientation, and greater interface with resources. All right, thank you. Next slide and the next one after that. Okay, so here's something we use with the officer. This is the first module I talked about using the interpreting the screen. So we give folks these laminated cards that have the 4 screening questions and then prompts. This is just an example of some of the tools. I think these next several slides are examples of the tools that the probation officers are using. So this is one. If someone flags in the state of North Carolina as answering, one of our 4 mental health questions, then the officer is supposed to get this laminated card and dig into each question and try to really confirm that there is a mental health issue before referring them on to a specialty probation. All right, so that's one tool. Next slide. This is what happens during our licensed clinical social worker case consultation. So this is what the social worker and the probation officer run through when a probation officer wants to staff a case that's particularly challenging. So we give this as a general guideline. It's just if you were presenting a case in grand rounds or a case, study in a class or something like that. But we really wanted to give officers the language that they needed to be able to communicate with the LCSW, but also to inform themselves and educate themselves. So this is just an example of the exchange between the LCSW and the probation officers. All right. Fascinating, I know. Go ahead, Steve. Decisional balance. So this is straight out of MI, right? Motivational interviewing. So someone, particularly substance use was an issue that probation officers were trying to address. So they'd go through a decisional balance and change ruler. So, on a scale of, 1 to 10, how confident are you that you could change your frequency and intensity of drinking, right? What are some benefits to deciding to change that? Sometimes it was around medication and engagement and treatment. Someone beginning change talk like, I do feel a lot better when I'm on my meds, but also, and I get in less trouble. But also I can't, drink as much when I'm on the medications. So, and then the probation officer would be trained up to take that language, right, and begin to find ways to motivate reduction, abstinence, if possible and appropriate, for substance use, for example. So again, one of the tools that the officers, especially officers, are trained up to use. All right. Go ahead, Steve. Yep, reasons to take. So an officer might sit down with a probationer who's supposed to be taking medications and say, hey, Gary, I'd like to talk with you a little bit, if you don't mind, about some of the reasons people who have a diagnosis like yours take their psychiatric meds. Do you mind if we go through this together? and you just identify which ones make sense to you. So then the officer would use this as a way to reinforce, motivate um, um, adherence to prescriptions that are pretty important for someone with a mental illness. All right, another tool. This is a good one. Some of you, feel free to apply this. I'll apply this to myself. So basically, how much am I spending on I'm a IPA beer drinker. So how much am I spending on my IPAs? Do we need to stop the recording, Steve? Was I not supposed to say that out loud? All
Too
right.
late. We've already passed it.
You'll have to expunge that from the record here. But if I just spent $1 a day, or $1 a week rather, on beer, I would spend $52 a year, right? So $1 a week every week, then my cost is $52 a year versus, if I did 364 bucks a week, for every week, that's going to end up being $36,000 on substances. I think that's right. Amount spent per day, yeah, on primary substance. So every day for 100 days, it adds up pretty quickly. So this is a tool. It takes a little bit of time to get used to how to use this, but illustrates how much, what would you rather be doing with your $36,400, right? What could you do with that? House, car, pay off debt, so forth. All right, so another tool we use, and then reasons for quitting alcohol or drugs, same notion as reasons for taking my psychiatric medications. But I would be happier, I would be safer, I would be less likely to be in the hospital, I would feel better about myself. So again, strategies that an officer is using to motivate change and to get folks to think about what they're doing. All right, so those are a set of tools. What else we got? Oh, I did a study of that specialty mental health probation versus regular probation, and these are some preliminary findings. And the specialty probation officers were much better at getting folks on their caseloads to complete their mental health action steps. So you can see the red bar were people on probation who participated in specialty probation. The blue bar was those who were in standard. So you can see on the left there, much greater mental health action step participation for those who receive specialty. We didn't find much difference in substance use. Can anybody suggest to me why we didn't find any differences in substance use between regular probation and specialty? Any guess is a good one. And I'll give you a hint. We talked about it earlier, if you were paying attention, in the slide deck. I'm sorry, Steve, what was that? Did you say because substance use is a criminogenic risk and all officers are addressing that anyway?
You got it.
That's exactly right. Very good. Well, good thoughts, Natasha. You're right. It was centered around everything that officers are supposed to be doing with specific attention to mental health. But as officers are just geared up to address substance use. So they're giving drug tests, they're referring folks to treatment. That's just baked into the job. And as I said, substance use is one of those criminogenic risks that they're easy. And if you think about it, that's an easy one to identify, right? Someone you can see a dirty drug screen more readily than you can see antisocial cognition, right? So probation officers are really geared up to address those things that they can address and can see tangibly. So that's my explanation, at least for the for the action, no pun intended, on the mental health side, but no difference on the substance use side, because all officers are trained up to do that sort of at a baseline. Okay, let's see. No, that's a good thought, Natasha. The licensed clinical social worker we had, not all of them do, but was trained, in dual disorders. So that was certainly a feature of the supervision, but an emphasis on substance use, or particularly co-occurring disorder or integrated dual disorder treatment, is necessary for this population. So that's a good insight. And I think, having an IDDT orientation to especially mental health probation is probably a necessary feature or adaptation. All right. Good thought. And all right. So another thing that I did in a study, I added a supported employment intervention to especially mental health probation, and did a study focused on that. This was funded by the Bureau of Justice Assistance, and I finished this up a little bit ago. But, one of the primary requirements on probation is, for anyone, is to get a job, right? Or have a job and sustain a job. Well, going out and getting a job with someone with paranoid schizophrenia, with no house, with substance use issue and chronic physical health problems is difficult. But that really is what folks on probation get penalized most for, probably second, or competing with substance use, is just not having a job. So I thought, let me try to address that by adding an evidence-based supported employment program called Individual Placement Support Supported Employment to especially mental health probation, and see if we can get better outcomes that way. So let's try to get people jobs, right? Let's take those barriers away. Still working on the preliminary results or analyzing the data. But one thing we learned, and again, this goes back to the picture we painted earlier on about the complex needs. Folks, once they get on probation or coming right out of prison onto probation, are not ready to think about a job. They've got so many of these other basic needs that need to be addressed before they're even ready to get themselves together to start working. So what we learned is, you can't start with the employment part of the intervention. You need a lot of case management, you need stabilization, you need a good 6 months to get folks ready for the IPS intervention before you can do anything else. So IPS really is supposed to be, it's a evidence-based practice that's integrated with other services. So, and it's really, as I reflect on my experiences with the study and the literature, it really is for those folks with severe mental illness who are sort of at the top, who have symptoms that are managed, who have skills that lend themselves to employment, and are stably housed, have social support. It's not for someone right out of prison who'd been in restrictive housing for the last 6 months, and there's a lot more that's needed than just the supported employment intervention. So that was a good lesson to learn, and I think for my next study, incorporating more of a case management, peer support model along with the supported employment and housing first, right? If we had to bundle together all of these evidence-based practices for folks with mental illness, it would be those things: housing first, supported employment, peer support, throw in substance use treatment, ACT, and so forth. All right, next slide. Wow,
Okay, slides.
there we go. We did it. Just under 6 hours. So there is my contact, and there's Steve's contact information. Now we've got, 25 minutes for question and answer, or however long we go. Thank you, everybody, for listening, and I'm happy to talk about whatever you'd like.
Gary, I'm gonna start because I've been holding one here since the beginning.
Okay.
But there wasn't a good spot where I felt like I could ask before them. So what is the best way do you, or suggestion, I guess, would be to get a program, a specialized mental health caseload program started in a jurisdiction? What is the best way to approach that?
Yeah. Um, so if there's a mental health court in your jurisdiction, then an easy avenue would be collaborating closely with the probation officers assigned to the mental health court. If you don't have a mental health court, how to start this from scratch? I mean, you really need to get the ear of probation administrators. I mean, it's not hard to convince them that mental health is a problem that they're dealing with, right? Because they're dealing with it. Um, uh, it's coming to them with a solution. Like we want to, and maybe it originates from a mental health, community mental health, reaching out to local probation and say, hey, we'd love to work closely with a couple of your officers who have interest in this, provide support, um, uh, and training and advocacy and linkage for the population. What I had the benefit in North Carolina of probation reaching out to me, and I was already doing research in the area and was known. So it was a little bit easier for me there. I imagine it would be difficult starting from scratch, and I would say it's all about relationships. So finding someone who works closely with probation, having a plan, like telling them exactly what it is you want to do and how it might benefit them, and then having early successes. Now, probation has to be committed because it's not a resource neutral thing because they are reducing the caseloads of some of their officers that are already employed there, but that comes at the expense of redistributing their caseloads to other officers, right? So it's probably rare where a probation department would hire brand new officers for this, rather they'll just reallocate resources. So, being clear that this is the model, here's how it works, how can we support as community mental health to serve a population of folks we know are already on your doorstep. I think, and it was sort of a long-winded answer, but I would summarize by relationship, relationship, relationship. So finding, um, um, someone who's got a relationship with either a probation administrator, officer, supervisor, or somewhere higher up at the state would be a start. So good question. Could it be billed under Medicaid? It could be billed under Medicaid by mental health. Probation, and again, this is a distinct difference, is not set up to bill anybody, right? They're not set up to bill Medicaid for the services they provide. Um, so, so Natasha, you're saying that the ability of probation in California to bill Medicaid is changing. That's good. Yeah. And again, on my most cynical days, I say let's just merge mental health and probation together. So those obstacles, right? The barriers to service access, billing, financing services are removed. Um, that's not ideal. We'd love to have no folks with mental illness in any part of the justice system, but this is our reality. So figuring out ways to remove those barriers, I think, and innovations like allowing probation to bill for Medicaid services directly is what's needed. Thank you, Scott, for um, the resource there. Okay. Other questions?
Harry, where'd that number of 40 come from?
That was from the sort of the prototypical model. There's an article out by Jennifer Skeem, Skeem, and the sort of the core elements of specialty probation were outlined in that article, and I think that's where it came from. But also might be a publication from Council of State Governments. Fred Osher, Osher, years ago published sort of typical elements of probation and mental health courts, I think. So the typical caseloads in North Carolina, for example, range from 70 to 120. And it was just untenable to think of having a caseload of exclusively probationers with mental illness 70. So it was also a number that the state of North Carolina was willing to get down to, with, you know, after they saw some of the same information about the complexity, the basic needs, everything that goes into this, agreed that this is going to take a reduced caseload to do well. And they even argued it could even be lower, because all of us who, you know, worked in mental health, carried caseloads, case management caseloads, or what have you, know that you get more than 3 or 4 folks on your caseload who are really active, doing poorly, can, you know, really create a lot of work and almost dominate the caseload. All right.
Any other questions before I?
So this was a laminated card, Christine, if I'm pronouncing that right. Yes, I can. Let's see. If you send me an email, I can share that with you. I think I've got it on another computer. The slideshow, yeah, I'm good with that. Steve, what's the policy of sharing these slides?
They could just email me and I can
Yeah.
email them to you.
Yep.
And this is being recorded and will be posted on our website as well.
Yeah.
Within the next week or two as well. I did not get any more questions on my end.
Okay. Well, thanks everybody. Don't hesitate to reach out if I can be of any help, or if you want to talk more, happy to share. Thanks for the opportunity.
Greatly appreciate you, Gary, coming on and speaking about this. There's a lot of good questions there, and I know that the slideshow will be very helpful, as well as the recording, to a lot of people. So again, thank you very much. And if anybody needs anything, please reach out to either of us. We appreciate everyone's attendance today.
All right.